Good morning, everyone. And today we have a very special Grand Rounds. Actually, it's a collaboration between our two departments here, departments of cardiology as well as Department of Obstetrics and Gynecology. And it's a pleasure to introduce Dr. TRISTI MUIR. She is the chair of Obstetrics and Gynecology here. She is really renowned for female pelvic medicine and reconstructive surgery. Trained at Mayo Clinic, Texas A&M, Cleveland Clinic, and with advanced training at the Cleveland Clinic with reconstructive surgery as well as emphasis on pelvic area. And also, she served in the U.S. Air Force and ranked Lieutenant Colonel. So it's a pleasure to have her here and collaborate. So I think it's great. Tristi, why don't you introduce? So we have actually 4 presentations. And we have a panel of experts, and these are experts that span from adult congenital heart disease, medical, surgical, anesthesia, OBGYN, high risk. So I think it's going to be a very interactive Grand Rounds today. So Tristi, why don't you introduce Dr. PIRICS?
Good morning. It's really a pleasure to be here, and I am so happy to introduce Dr. Michael PIRICS. He did his medical school training down the road at Baylor and residency here at Houston Methodist, and we're very fortunate to have him as faculty here, and then he has appointments with Texas A&M and Weill Cornell. He's in charge of our Grand Rounds, but very importantly, he's one of 2 of our physicians that are dedicated to taking care of these very complex pregnant women. And I really look forward to hearing more about the interaction between all the disciplines. I think that's tremendously important for taking care of not only one patient, but when there's another one on board. So I look forward to the day, and thank you for inviting us.
Thank you. Thank you very much. So Dr. PIRICS would be one of our panelists. And our speakers in order will be Dr. LIN, who needs no introduction. He's the director of our Adult Congenital Heart Disease Program, also Associate Director of the program, of the Cardiology program here at Houston Methodist. Dr. MYUNG Park, who is the chief of our Heart Failure Division here at Houston Methodist, and certainly her interest is pulmonary hypertension and heart failure, trained at Cleveland Clinic. Dr. Tom MACGILLIVRAY, who also doesn't need any introduction. Chief of Cardiac Surgery and Thoracic Transplantation, Jimmy Howell, Chair at Houston Methodist, and previously trained and obviously made his name at Mass General in areas of aorta surgery as well as adult congenital heart disease. And Dr. Gary Monteiro, who's our staff anesthesiologist here, interested in adult congenital heart disease anesthesia as well as pediatrics. He trained both in adult as well as pediatrics. I think he's going to give us a great perspective from an anesthesia point of view in these high-risk patients. So without further ado, let's start with Dr. LIN. And we asked them to take 10 minutes. We take some questions afterwards and then move on, and hopefully we'll leave something towards the end.
Great. Well, good morning. We hope you'll enjoy this. I think this is going to be kind of an interesting format that's going to be a little bit different than what we usually do. So to start off with, these are my disclosures. And so the major objectives are typically what we're going to try to do is go through major cardiovascular diseases that can impact the management of our pregnant patients. We're going to describe indications and mechanisms of obtaining cardiovascular consultation and support for these pregnant patients. And then we're hopefully going to give each speaker is going to give some learning points about different types of diseases that can impact pregnancy, and then how to actually manage and refer these patients and how to get them early care, which, as we all know, is probably one of the most important things to do. And so each of our speakers is going to cover a slightly different topic, which hopefully will give a comprehensive look, but of course not complete look at all the cardiovascular diseases that can affect pregnancy. So from my standpoint, one of the most important things about why we are here today is that the 20th century really showed us what we can actually do in cardiovascular care. Specifically in the congenital heart world, it really became possible for the very first time for a cyanotic heart patient to actually survive to adulthood and, of course, then become pregnant because of the Blalock-Taussig-Thomas shunt that was first done in 1944. And of course, nowadays we take it for granted that there was cardiopulmonary bypass, but really there was no cardiopulmonary bypass before 1953. This is something that gets done hundreds, maybe even thousands of times a day across the world. But it was impossible until 1953, which meant it was also impossible to successfully operate on a neonatal heart until that point in time. And then, of course, with this, just like with Mickey and his success at invigorating these broomsticks and buckets, we then made it possible for tetralogy Fallot patients to survive to adulthood, and thereafter transposition to great arteries with the first repair in 1957. And then after that, there was a huge advancement in the fact that we were able to get hypoplastic left heart patients to survive early childhood and then to adulthood. So now we're actually dealing with this, where we have a situation where we have all these successful congenital heart surgeries and all these successful congenital heart patients that are surviving to adulthood for the very first time in history. And what that therefore means is that we have a population for the very first time that can become pregnant and many times actually go through a successful pregnancy. Greater than 90% of children born today with congenital heart disease are actually expected to survive adulthood. And so therefore, we often think of the adult congenital population as a tidal wave that will soon be impacting us. And so this is just what it looks like over time about how things have gone. And then likewise, this is actually a recent study that showed that actually adults with congenital heart disease are being admitted almost as often, and now probably more often than pediatric patients with congenital heart disease. And it actually looks like there's about 1.5 million adults with congenital heart disease in the United States, expected to go up to 2.2 million adults with congenital heart disease by 2020. And about 80% of pregnant women with cardiovascular disease actually have a congenital heart disease lesion, and that is why they have a cardiovascular disease. And so that's why this becomes extremely important for us to deal with. The other reason why it becomes very important for those of us in this room to deal with is that history has a lot to do with the survivors of congenital heart disease. So for example, basically, if you think about 60 years ago, the only way you could potentially survive childhood with a serious congenital heart lesion is if you were actually born in a region like Houston, or your parents actually brought you here. And 60 years ago, you just didn't fly back and forth from the place where you got operated on. You actually stayed there. You lived there. Your parents actually often had to move there. And so we have actually a larger population of adults with congenital heart disease than most other places in the country, other than the other major surgical centers that were historically part of that. So the problem with this is, of course, they're going to show up unannounced. They're going to show up very sick when they show up. So for example, they're going to show up with unrepaired defects in Eisenmenger syndrome. They may actually even have pulmonary hypertension even after repair. They may show up with single ventricle without having any history whatsoever. And they may even show up with paradoxical embolism in pregnancy. And so the real goal to this is to actually try to identify them early and get them preconception counseling. So that is where the Class 1 guidelines are at this time for ACC/AHA as far as adult congenital heart disease guidance for pregnancy. The goal is really to get them pre-pregnancy and give them counseling pre-pregnancy. And as far as this is concerned, we also would like to get them genetic counseling. We like to talk about timing of pregnancy. We like to talk about the medications that they can and cannot take during pregnancy. And then we also want to talk about their birthing plan. What is going to be safe for their pregnancy? What is going to be safe for their labor and delivery? So let's go ahead and get to our case. So this is a 37-year-old woman, G3P2. She actually had a history of a restrictive ventricular septal defect. And these, we know, generally speaking, don't actually impact patients. Most of the time, they don't need anything done. She did have a history of diastolic heart failure after delivery in the past, after her second pregnancy. And this time she was actually referred to us at 27 weeks, a little bit later than we would have liked to, knowing her past history, with increasing shortness of breath and lower extreme edema. So this is potentially a very hot patient, a patient that could potentially get into trouble very quickly. So the management, initially we were able to actually manage her with just oral diuretics. She did well for about 4 weeks. Now we're into the 30s. We increased to 10 milligrams as she started having more and more shortness of breath and edema. And then this time she started desaturating, or at least there was a question of desaturation with ambulation. And then the primary cardiologist at this point raised the question, does this patient have severe pulmonary hypertension, and should we talk about not going through the pregnancy? Well, it's a little bit late at this point in time because we're in the 30s, 30-something weeks. But then the question was, well, should we have just terminated the pregnancy early if she did have pulmonary hypertension? So what we did, in collaboration with the pulmonary hypertension service in our group, Dr. Ashraf Guha, we actually took her to the cath lab, and very safely, with minimal fluoroscopy, we were able to confirm that she did not have pulmonary hypertension, and she actually just had a shunt, as we expected, about 1.4 to 1, something, again, that we don't expect needs surgery. She was ultimately admitted multiple times during the final 4 weeks with question of labor and then some mild diastolic heart failure. She ultimately underwent C-section. But then we actually had to diurese her pretty aggressively because she started going into worsening heart failure around the time of her delivery. And it turns out that it's actually pretty important to have telemetry on these patients because when they get diuresed aggressively, they start to have ventricular ectopy. She actually had very frequent ventricular ectopy due to low potassium and magnesium as a result of diuresis. Something we take for granted in our typical cardiac telemetry floors, but not something that we necessarily do regularly in LND. So at the end of the day, hopefully what I've emphasized to you in this particular case is that early referral and a low threshold for referral for these patients who are just contemplating pregnancy is probably a great idea. We really want to talk about pre-pregnancy assessment. We want to talk about what kind of medications should they be on. Should they start on their folate? Is warfarin okay? Should they be on Lovenox or heparin during their pregnancy? Are ACE inhibitors okay? Which obviously they're not. ARBs are not okay either. So if they're contemplating pregnancy, you need to stop those and transition them to something else. And then of course, likewise, we want to get them genetic counseling because a lot of these diseases are genetically passed on. And the interesting part of my job that has developed in the last 5 years is that I've had to start to talk about contraception. What is safe for these patients? If they have a right to left or left to right shunt, what contraception therapies are actually safe for these patients and which are not? How long should they be on them, et cetera, et cetera. And then of course we like to do frequent cardiovascular evaluation, especially if they're actually symptomatic. If they're less symptomatic, we can see them sort of once a trimester or less. So finally, these are our contact information. We have a dedicated line now for the Adult Congenital Heart Program. It's 12894. And of course, if there's something urgent that's actually coming in sick, I'm happy to take any calls directly. These are our successful pregnancies during 2017. As I mentioned, the VSD with diastolic heart failure. We had a patient with an ascending aortic aneurysm where there was a concern for increasing size. We had a Ross procedure that was delivered actually in El Paso, who did well despite an neo-aortic root aneurysm and aortic insufficiency. We had a patient with detransposition who was actually potentially very sick with systemic RV failure, and she actually did very well. Tetralogy fellow who actually just delivered on Tuesday. She had severe PR with right ventricular enlargement. We had a patient with anomalous right coronary artery with an interarterial course who frequently presented with episodes of chest pain. And then finally, we had a double-chambered RV with diastolic heart failure who actually ultimately did very well. So thank you very much.
There you go. I think the plan is if there's any specific questions, I'm happy to answer one or two between presentations. So we'll open it up for a little question and answer, potentially.
Particularly, it goes through adult congenital heart disease here area. Huey, what are the broad categories where women should not get pregnant? Is this pulmonary? The broad category. I know it could be a lecture, but where you really should not get pregnant with patients with adult congenital heart disease.
So it's actually interesting. One of the things that we've started doing a lot in the field is try not to tell people who can and cannot get pregnant because we think that that's actually really their decision. What we do is we try to advise who would do better with pregnancy, who would not do well with pregnancy. Obviously, as we all know in this room, the typical ones that we are always worried about are the patients who have Eisenmenger syndrome or severe pulmonary hypertension. We know that that can be potentially catastrophic, especially second and third trimesters, in which case it's already pretty much too late to do anything for those patients. And we can just hope for the best to get them through. It can be done. Okay, Eisenmenger delivery can be done, but it can be a very rocky course. The other patients where we get a little bit anxious is patients who have single ventricle physiology. And the problem is a lot of times they actually don't know that they have single ventricle physiology because they'll come to you with a diagnosis of quote-unquote transposition, or they'll come to you with a diagnosis of AV canal. And you'll think that that's what they actually have, but in fact they're actually a Fontan. And in which case then the question becomes, are they a right dominant Fontan? In other words, are they living off of a right ventricle or are they living off of a left ventricle? If they're living off of a right ventricle serving as their systemic ventricle, that becomes a problem. That can become very, very challenging during the third trimester. And then, of course, the other patients that we get very concerned about are patients who have severe aortic dilation, whether that's the neo-aorta after a transposition or Ross type of procedure, or patients who have intrinsic aortopathies with aortic size of about 5 or larger. That's when we get a little bit concerned about them tolerating pregnancy. Obviously, in those types of patients that I've talked about during this, those are the patients that we really need to do preconception counseling, and we really need to talk about what kinds of contraception should they be doing so that the pregnancy is planned if they do want to go forward with the pregnancy. But of course, we want to give them all the understandings of what the risks are so they go into it in an informed way. Thanks.
question?
Yeah. Huey, quick,
Do we have time to take it?
Yes.
a quick physiology question. VSD and diastolic heart failure in the context of pregnancy, is it because of more total body volume, or why do you expect diastolic heart failure with this case?
That's a challenging question. I think it would be hard to tell in this particular patient. I think she's got multiple risk factors for diastolic heart failure external to the VSD. I do think that it would not be unexpected that she would develop diastolic heart failure. So one of the things we often forget about in the adult world is that VSD actually presents in childhood with left-sided heart failure, so left-sided overcirculation. And so you can imagine that in a normally restrictive VSD, when you challenge it with a load, just like if we gave any of us a 10-liter saline bolus, we could potentially go into diastolic heart failure. But even more so, somebody with a VSD, they're going to load the pulmonary circulation, and they're going to load the left atrium because of all the left to right shunting that occurs. And so I think it's not too surprising, but in her case, I think it's probably multifactorial. I do think that it is a thought that we should probably start to look into more and more in the future as more and more of these patients go through pregnancy. Is a restrictive VSD potentially something that we need to look into pre-pregnancy and watch these patients a little bit more carefully so they don't just show up at the end of the third trimester really sick?
I mean, this highlights the importance of teamwork between the cardiologist, and I think this whole grand rounds would be about, and whoever else is involved in the care of these patients, high-risk patients. All right, Dr. Park,
Thank
you're going to
you. Good
address
morning.
systolic heart failure.
Yes, sir. I want to share a story of a very unique individual. I think a lot of us in this room actually know her. So this is a 40-year-old Asian female that was referred to me from Cleveland Clinic for evaluation and further management of cardiomyopathy and pregnancy. And at the time, she was about 10 weeks pregnant. Now, she has some interesting childhood past medical history in that she suffered from a sacrococcygeal teratoma at age of 2. And this was treated with radiation and adriamycin. She was cured from this childhood cancer, had normal development, normal schooling, and was a very busy and active professional female. She had recently gotten married and actually was on her 40th birthday. She was hiking at nearby mountains, and then she had a stroke. And it was acute, it was felt to be embolic, and she was admitted to an outside hospital here in Houston. And it was actually at that time, for the first time, she was diagnosed with cardiomyopathy with EF of depressed of 30 to 35%. And at the same time, as you would have it, she was shown to be 6 weeks pregnant, and she was undergoing in vitro fertilization for 5 years due to infertility. So she was 40 years old. She was been trying to have a baby for 5 years. She just had a stroke, and she was told that she had a pretty devastating and severe systolic heart failure. So during the initial evaluation at the outside hospital, she had marked non-sustained ventricular tachycardia. She was placed on life vest, and she was so symptomatically hypotensive and the blood pressure in the 80s and 90s that it really limited the physicians over there taking care of her from initiating or titrating any of the heart failure regimen. They had multiple consultants on board from multidisciplinary group, and the termination of pregnancy was recommended across the board due to the extremely high risk maternal and fetal morbidity and mortality. She refused to accept this. This has been a life goal to have a family with her husband. She understood what was at stake, and she saw second opinion here in Houston. She got the same opinion, and that's when her husband actually drove her to, or took her to Cleveland Clinic. And there, recognizing that it is not 100% she has to terminate, but she really needed care near home. And I know the team there, so that's why they called me to say, hey, can you see this lady? She really needs help at a place that is closer to where she lives. So upon seeing her, these were medications. She was on aspirin, she was on Lovenox, some iron, and a little bit of Lasix, and tiny bit of metoprolol, which she tells me that she only took it maybe half the time because her blood pressure would drop. She's really a fragile appearing female, and she was short of breath walking into the exam room. And I can tell you that she's about, she makes me feel really big. So that kind of tells you how frail she is. And I think, at the top of her pregnancy, she did not go over 95 pounds. And what was most interesting is that she was tacking away, having a lot of ectopy, a pronounced systolic murmur, and edema. Again, now this is maybe 11 weeks. It was clear that she's going to struggle. Her data from laboratory-wise was really not that remarkable. She did have a little bit elevated BNP, and her echo demonstrated that she indeed had a marked systolic dysfunction. And at the 4-chamber view, what was concerning for most likely an LV thrombus. So risk assessment, when you list them, is pretty pronounced. Advanced maternal age, she's pregnant with twins, and then which was shown to be through ultrasound. Her physical stature, and she also has scoliosis, which again adds an additional challenge. Severity of her LV dysfunction, ventricular arrhythmia, which she was having on throughout her whole every day, and hypotension, which really limited any initiating or titrating her therapy regimen, and a recent CVA, and the risk of thromboembolism, especially with her apical thrombus, and her progression of symptoms, and she really needed help with even the basic elements of her care, even early in the pregnancy. So why is this such a challenge? Of course, we all know this with a significant increase in blood volume that starts very early in the pregnancy. It tops at the 3rd and final trimester. And of course, with potential for rapid autotransfusion from placenta. Again, peripartum period, so being so critically important in careful monitoring because they can really decompensate during this time. The peripheral vascular resistance goes down throughout. The heart rate and cardiac output continues to increase from the first throughout the pregnancy, and then of course peaking at the peripartum period. The goals of management, and this is all from guidelines that mention of heart failure and pregnancy to stabilize hemodynamic status, relieve the patient's symptoms, and of course ensure fetal safety. And the delivery, spontaneous vaginal delivery is preferred for those who are hemodynamically stable, and as an outpatient, C-section is the preferred when they're unstable or critically ill. And prepare the need for mechanical support, balloon pump, ECMO, what have you. These conversations need to be had early. And of course, termination of pregnancy, as been mentioned, is an important treatment. And this is the conversation that needs to be discussed early, as we've been discussing. So with her management, I saw her almost every week for the first about a month or so, and we utilized that time to bring other team members actually to have a frank discussion. We talked about the need for mechanical support. We talked about the need for an LVAD, and all the complications that she can potentially face, arrhythmia, stroke, death of her and her babies, and the fact that if she survived this, in the end, she may need a cardiac transplantation. Risk assessment was performed with all the multidisciplinary team. All of my team met with her on an individual basis. We also engaged the service of ethics team. I wanted their input as to having a discussion with her about the risk and the benefit. Our cardiovascular surgeons were also involved. And of course, our high-risk OB and our maternal fetal service. They're all part of this initial discussion. And at the end, she decided to stick with her decision, and she wanted to proceed with pregnancy, knowing all the risks and having heard from multiple voices. So going forward, she, not surprisingly, she did experience decompensation. Now this is a week about 16 or 17 with worsening shortness of breath, tachycardia, hypotension. She was admitted, and we underwent her catheterization. As you can see, she had a relatively low cardiac output, but her filling pressure and other parameters were within normal limits. We kept her in the hospital for about 2 weeks, did a very careful monitored titration of her heart failure regimen. I mean, taking in tiny minuscule amounts to see what she would tolerate, adding digoxin, hydralazine, and increasing her metoprolol. She did tolerate this, and she was sent home. She was admitted again with worsening symptoms a couple of weeks later. Again, tachycardia, non-sustained VTAC with worsening shortness of breath. And this time she got hypoxic, and she required more diuresis and some oxygen. And a third admission, we had a long discussion about the fact that this is becoming a little bit too dangerous, that she really needed to stay in the hospital. We admitted to 411, again, because that's where we have the telemetry unit, and she was clinically in low output state, so she required a little bit of dobutamine. Her arrhythmia burden was significant. There was a daily fetal monitoring that was performed with multidisciplinary team. And again, all of us in the heart failure team, high-risk OB, maternal fetal service, and neonatal team, we saw her every day and to ensure that indeed she was staying stable. In the midst of all this, we met actually several times and with all the team members present, including anesthesia, delivery team, critical care team, neonatal team, aside from the heart failure team and the OB team. And we held meeting to discuss logistics delivery, who needs to be in the OR, and how to handle emergent situations. Should it happen at nighttime? Should it happen on weekends? And this was right around, actually now, around Thanksgiving and Christmas, and we who'll be on call if she, goes into, she ruptures on a Thanksgiving, how are we going to handle that? So we sort of set expectation goals and communication system in the event of emergency should that occur. Delivery day, 30 weeks is the day that was best thought to be to deliver, and she was by then unstable with daily arrhythmia, low output state. She was taken to Fanjin OR where a PA catheter was placed with a balloon pump. She was intubated and she underwent C-section. She was able to be extubated soon thereafter, and she came out to the CBICU. And throughout all this and sticking to her guns, and she was able to deliver successfully twin girls that you see right here. And actually, next week they will be turning 2, both of them. And it's an amazingly great story. But what we have learned as a team through all this is that the optimal treatment of underlying heart failure is very critical with very close follow-up. Detailed discussion to put them in the perspective of what they're really facing, both the husband and the wife, and to give them the opportunity whenever possible early in the course. And multidisciplinary team. I know this phrase gets said a lot, but I really cannot say this enough for the appreciation of everybody that really came into being. I mean, we had about, I think, 20-some people in the OR for her delivery that day. And it was an astounding an array of support. And to discuss the logistics and do this early and to prepare for emergent situations. And it was, I just saw her in clinic actually last week, and she is so grateful for the opportunity to have this lovely family that she now has. Her current EF is about to 30 to 35%. She now has a defibrillator. She has been titrated on her beta blockers. She still weighs barely 90 pounds, and her blood pressure is still in the 80s or 90s, but she's able to stay home, take care of her family, and actually enjoy being a mother. So thank you so much for your attention.
I think mirroring the words about multidisciplinary team, this is not the kind of pregnant patient that I would want to deal with probably ever. And the only way we were able to have the support we did was because of the multidisciplinary team. This kind of delivery would not occur at almost any other hospital that I can name, just because of the amount of involvement that it took to get this team together, to get anesthesia lined up, to get the neonatologist on board. I mean, it was a big process, and I think it's really crucial that we have these relationships between departments, because this kind of patient is going to be coming more and more often, knocking on my door, accidentally pregnant or intentionally pregnant, and probably shouldn't have been in some cases. And we're going to be seeing a lot more of these because of the adult congenital heart disease patients that have survived to adulthood, and so this kind of interdisciplinary approach is going to be more and more important to have successful things like this. I look at this picture and I cannot believe it's been 2 years. It's awesome.
I know, me too. And then one thing I think I failed to mention and would like to say thanks is the nurses in the Foundry 11 and the labor and delivery nurses. I mean, they really did work together because there had to be education in both ends. So, I mean, there was such a cooperation amongst all the individuals in the care of this one individual, or 3, that it was, and I agree with you, Michael, and and your input. I mean, I just want to thank you and Gary. I mean, all of your team members was just super.
Thank you, Dr. Park. Dr. McGillivray.
Well, that's a great case. I'm going to talk about the use of mechanical circulatory support for OB obstetrical emergencies. I've had an interest in neonatal and prenatal surgery anyway. I was involved with the early fetal surgery program, in fetal cardiac surgery program in San Francisco. And when I got to Boston, it changed. I had a different interaction with the obstetric service. I took care of the chief of OB who needed a BiVAD support and heart transplant. This all sort of folds into place. I was making rounds on a Saturday morning and heard a stat call, a code call to the obstetrics suite. I thought for sure it was him that had arrested rather than the case that I'm about to talk with you about. This is a 43-year-old woman that ended up being a CPC in the New England Journal of Medicine that I helped take care of. And she's a 43-year-old woman. She had 4 previous uneventful deliveries. This was her 5th pregnancy. Her previous pregnancy was 14 years earlier, and she had had a couple of episodes of vaginal bleeding. She had been evaluated placenta previa, and then when she was admitted, she had some more actually significant bleeding and was brought in for an urgent delivery by C-section. So she had a spinal anesthetic. Up until I was involved, it was a pretty uneventful C-section. Nice, healthy baby boy with good APGAR scores. And while they were closing the fascia from the C-section, the mother became acutely bradycardic and hypotensive, but felt pretty well, didn't have any complaints. And then a few minutes later complained of chest pain, and the anesthesiologist, in talking with her, noted that suddenly her lips became stark white, her eyes rolled back in her head, and she became apneic, pulseless. So they started doing CPR on her. This is the OB anesthetic record, and I don't know if I can see I guess I can use a pointer here. Whoop. So she's fine until she becomes bradycardic, becomes pulseless. She's in pulseless electrical activity. The anesthesiologist very expeditiously intubates her. Good respiration. You can see the lungs going up and down. Good breath sounds. End tidal CO2, though, is 0. And they continue doing CPR, give her boluses of epinephrine. Blood pressure comes back. She wakes up. But within a few minutes, she goes into pulseless electrical activity again, and this cycle continues. So differential diagnosis of cardiopulmonary collapse is, it's a long differential diagnosis, but a relatively short one. The usual hemorrhage, sepsis, endocrine emergencies, certainly vasoplegia from some of the medicines and from spinal anesthetics can do it. Certainly worry about vascular crises, either dissections or ruptures. There's a whole litany of cardiogenic causes in certainly women in her 40s, whether it be coronary problems. Could be arrhythmias, but we know that she didn't have an arrhythmia because she was being monitored. Other congenital or cardiomyopathic problems. But then there's the issue, and was the issue with this woman, were embolic problems. Certainly thromboembolic pulmonary embolism. Ear embolism has been reported in patients having cesarean sections and pelvic surgery. And unique to obstetrics are amniotic fluid emboli or fetal tissue emboli to the mother's lungs. The echo, and again, I don't have any moving echoes. This is from the article, but the TEE that was put in shows dilated right ventricle, dilated right atrium, pretty severe tricuspid regurgitation. And certainly the right ventricle compared to the left ventricle, pretty dilated right ventricle. So we made the decision to cannulate her for veno-arterial ECMO through the groin. I mean, there are a number of different options for mechanical support, but given her mechanical and respiratory problems, we thought VA ECMO was the best. There's a number of different the cannulation strategies. You can use VA ECMO, you can use VV ECMO, certainly in obstetrics patients, and I'll get into this a little bit more later, but VV ECMO for patients with the flu, H1N1, particularly have been supported with VV ECMO. Both require anticoagulation. This woman, with the anticoagulation we gave her, had significant bleeding from her uterus. We actually had to do a hysterectomy in the ICU because just to control the bleeding. There's not a lot of experience with mechanical circulatory support in pregnant women. This is a report out of Birmingham, Alabama. They reported 4 cases, and they did a literature search, and there were 31 studies coming up with about 60 cases, and that they had mostly of their 4 cases, 3 of them were ARDS. One was circulatory cardiogenic shock that they treated with VA ECMO. And again, in the literature, most of it is VV ECMO for ARDS, but you can use VA ECMO for support of the mother, and the outcomes for both the baby and the mothers are quite good. The big issue to deal with is bleeding. So circulatory collapse can happen in pregnancy and in the peripartum period. Rapid diagnosis and resuscitation is important. And again, it can't be stressed enough, the team-based approach. I think that the rapid diagnosis that we had with the transesophageal echo, putting all the pieces together, having the perinatal team manage the mom and the baby and anesthesia and cardiac surgery and then the ICU, really couldn't have been done. I think more importantly, knowing that the different expertise exists down the hall or around the corner, and knowing when and how to call them is very, very important. In this case, and I think in many cases now, echo is really easy to get. You can get a lot of information. You can get it quickly and accurately. And mechanical circulatory support can be used in women who are pregnant, even in the postpartum period, and it can be life-saving for those women. Thanks very much.
Thank you very much, Tom. Any questions for Dr. McGillivray? Quite an impressive clinical scenario there. All right, Dr. Monteiro.
They're beating down the door to come to this lecture.
I mean, the door is open. They can walk. They don't have to break the wall to get in.
So I have no disclosures, financial disclosures, of course. Okay. Today I'm going to discuss a patient that we had for a repeat C-section with a history of hypertrophic cardiomyopathy and von der Neue. Past medical history of this patient. She's a 33-year-old female presenting for repeat C-section and tubal ligation. She has a known HOCM diagnosis, and she's currently the only medication she takes is prenatal vitamins and Toprol XL daily. She's followed by an outside cardiologist who referred her to an OB here, and then the OB contacted me, and then I contacted the cardiologist, and that was a lot of phone conversations. She's had an active, uneventful pregnancy. She's term, and she's pretty stable. Her vitals are there. So just a little background. We see HOCM a lot because we're a cardiac operating room here. Different acronyms, depending on when and where you're reading. Pretty common in the general population, up to 0.5%. 600,000 adults in the US, give or take. Affects all races, ethnicities, 50-50 male to female, but we're only concerned for this lecture with the 50% that are female. And it's the number one cause of sudden death in athletes. Oh, that's sideways. If you turn your head sideways, you can see a really enlarged intraventricular septum, and it's just an example of, on the anterior leaflet, you see some SAM. Autosomal dominant, a couple of genes identified, diastolic dysfunction, and we think about having a gradient, dynamic gradient across the LVOT. So this is a dynamic left ventricular obstructive type lesion. So last time she had a C-section, it was at a neighboring hospital, standard ASA monitors, which basically means pulse ox, a 5-lead, blood pressure cuff, temperature. Sat her up, did a spinal anesthetic, and she promptly arrested. Resuscitated with multiple liters of crystalloid, pressors, intubated, of course. Pulmonary edema, was in the ICU for an extended period of time, and ultimately was discharged with AICD. Her cardiologist currently notes that her LVOT gradient exceeds 90. So one of the things we did was we had some sort of multidisciplinary, since that's the theme today, planning conversations. And this mother was dead set on being involved in her pregnancy. She did not want a general anesthetic if it could be avoided. We were asked if it would be okay if we provided some sort of neuraxial or regional anesthetic, and I said, yeah, of course we can do that. We placed 2 IVs under local anesthetic, no problem. Placed a radial artery arterial line under local, which is very common for us to do here. We sat her up with full monitoring and placed a lumbar epidural. At that point, we laid her flat. We started a phenylephrine infusion on a set carrier line going to one of those IVs and started to preload her with just a little bit of crystalloid. And then over a period of 30 minutes, we gradually brought up her epidural. 5 cc, for the anesthesia people, 5 cc boluses of just 2% without epi. Over 30 minutes, giving her time to compensate for the sympathectomy that would occur with an epidural, making sure we just brought it up very slowly, that she was comfortable, that any physiologic changes that happened we could compensate for very easily. Made sure that we didn't use epinephrine in the local anesthetic that we were giving through her epidural, because epidural epinephrine at low doses is associated with a farther decrease in the SVR. Phenylephrine was just adjusted for constant afterload, and when the OBs were ready, we tested her level, and we had a blood pressure that had started at 128/74 to 124/57. Heart rate was 92 at the surgical start. Uneventful intraoperative C-section. We gave her a total of 2,000 cc's of crystalloid. Approximately 600 of that was a preload, and then the rest of it was replacing blood volume. We had the cardiologist in the room with us, talking to the patient the whole time, so it was actually a really nice, calm setting. We had about 800 cc's, give or take, of EBL, standard IV Tylenol, a little bit of Zofran and Phenergan at the end, just a touch because she had an upset stomach, and then oxytocin infusion per OB. Overnight, we placed her in the Fondren ICU, uneventful. The cardiologist had requested that we left the epidural in place, just as an additional modality for pain control. We gave a small dose of epidural morphine, which typically lasts, people say 8 to 24 hours. The pain relief usually lasts about 8 hours. The itching lasts about 24 hours. Phenylephrine was weaned off very quickly, and then she's going to be scheduled for septal myectomy that wasn't scheduled yet. The take-home points is you have, I specifically didn't pick a congenital patient, but this is a very common disease. We see it all the time for cardiac surgery. But patients with varying cardiovascular diseases, the anesthetic plan or the anesthetic technique itself can directly cause decompensation of their cardiovascular condition. When they not they, but in a patient with HOCM, is not going to tolerate a spinal anesthetic. I can tell you that much, especially when they have a LVOT gradient in the 90s, because number one, they're sitting up typically, and then you're going to do your spinal, and you're going to induce a rapid sympathectomy and decrease preload. And you know, it's a very rapid anesthetic and directly cause decompensation. Typically when we're doing anesthetics either for C-sections or labor analgesia in decompensated patients or patients with the propensity to decompensate, slow and low is the way to go. Typically when women are laboring, slow and low is not something they're interested in, but this is where all the multidisciplinary and pre-delivery planning comes into place. If they know you're going to come in labor and we're going to do plan A, and gradually over the course of a couple of minutes, 30 minutes in this case, you know, or 15 minutes, you're going to have relief of, or we're going to set up the surgical condition. It's very easy if there's pre-planning. If it's an emergency situation, we've had some of those in the past. The anesthetic itself can exacerbate, just the emergency anesthetic can exacerbate the hemodynamic instability. So any planning ahead of time where we have plan A, B, C, we have all the people in the room is the way to go. And then any questions? So.
I think it's really been pointed out today how important that multidisciplinary approach is, and I can't emphasize enough the planning that takes place. And not only the planning, like this is the delivery plan, anesthesia plan, cardiology plan, post-delivery plan, but also who are the players and how to contact the players and get them on board. Because, you know, babies come at any time, right? And somebody can show up at any time. And having that plan and having it very accessible to whoever is around is key. And just amazing cases and excellent care that we've seen in all of these patients.
I just had a question, Gary. So great case. Just comment on the role of echo, if any, in a case like that where you've got known hokum, and obviously you don't want to put a TE probe because she's awake and alert, and you just sort of have ready access to it, or any transthoracic.
We have it in the room because we did it in Fondren, so we have access to TE probes all the time. We didn't do continuous TE monitoring or intermittent TE monitoring. It was available if we needed it. But again, the plan, of course, is slow controlled, and then her decompensation, if she decompensated, we already sort of knew what the etiology would have been at that point. So,
I was going to make a comment about the anesthesia part of this, since you mentioned the pain during labor. And so I think a lot of this is patient expectations and patient understanding of what is the plan. So, for instance, we did deliver Huey mentioned earlier, a patient this week with repaired tetralogy of Fallot. And so we had talked a long time about anesthesia and, you know, not to wait until it got out of hand in case we needed to do things. I mean, this is a totally different situation, obviously, but so that she is aware that here's what we're going to do. You should not wait until things are out of control. We should do this as controlled as possible. If we can plan a delivery for a time when the most people are in-house, haha, that never happens. She delivered at 3:31 in the morning, of course. And so, but all of these things so that she shows up and knows kind of what is going to happen as best as we can predict. The dangers, of course, when they show up over Thanksgiving weekend and there's no telemetry on L&D and all these exciting things. So, but the patient education about pain management is a really important part because that is a major part of labor and delivery.
Any other questions? Your thoughts, since we have all the experts here. I've heard, you know, in heart failure, you know, C-section is maybe preferred. Vaginal versus, you know, C-section and cardiovascular. I mean, is there any big guidelines? Yes, for the cardiovascular patients.
I would say that in general, we tend to prefer vaginal deliveries because usually the situation is a little more controlled. Blood loss is less. Volume management's going to be a little easier to control. But there are certain cases where if a C-section is planned, like if a patient had a previous C-section, they might not be a good candidate to have a vaginal delivery after a cesarean because of this. I don't know if I would encourage this type of patient to take on that risk as well. And so I think, again, looking back to the patient's history, their expectations again. The twin delivery is an interesting issue because normally we try to deliver twins vaginally when we can, and that particular provider is a skilled deliverer of twins. However, that was not the case to risk that. And so I think it's going to be case by case in each situation.
I think historically there was this concept of cardiac delivery, which historically was the high forceps delivery before any laboring, but I think that's largely gone out of vogue.
Yeah,
high
forceps. There's no one does that.
Yeah, I mean, a historic concept,
Yeah.
not to even allow laboring in these patients, but it's largely gone away.
But we still will do cases where in a patient that is not able to Valsalva or something like that, but wants a vaginal delivery, we can still do assisted deliveries with forceps. You basically labor them all the way down to the perineum, basically, and then do an operative delivery. And so that there is still a role for forceps, but high forceps is pretty rare. I was actually delivered by high forceps randomly, and my OB-GYN was old when that happened. So that's it's old.
So I would say from our standpoint, the classic one that everybody talks about is Marfan syndrome aortopathy. So if you have a high-risk Marfan syndrome patient or aortopathy patient, I think that those are typically the patients that we want to try to avoid having them labor and push, et cetera. So.
Well, I want to thank our speakers and our panelists for an amazing discussion today. And it's comforting to see that, even the very high risk, we have a wonderful team in cardiovascular as well as OBGYN and anesthesia to help take care of these patients. And thank you again for being here.